Good morning, everybody, and welcome to today's edition of the Insight APSAD webinar series. My name's Ben. I'm an educator here at Insight, and it's my pleasure to be introducing our speaker today, Dr. Brendan Clifford. Before we start, I'd like to begin by acknowledging the traditional custodians of the lands and waterways throughout Australia, paying respects to elders past, present, and emerging. I also extend that welcome to any Aboriginal and Torres Strait Islander guests who might be joining us today from around the country. I'm coming to you from Meanjin or Brisbane on the lands of the Turrbal and Yuggera peoples, and I'd like to acknowledge the ongoing impact of colonisation on our First Nation Australians, including the disproportionate impact of substance use on their health and well-being. As I mentioned, today's speaker is Dr. Brendan Clifford. Brendan is a Senior Research Fellow and Policy Lead with the National Centre for Clinical Research in Emerging Drugs, or NCCRED. He's a clinician researcher who uses interdisciplinary methods to further health equity and to enhance access to evidence-based healthcare. And today, Brendan's going to be speaking to you about the Prompt Response Network. We're going to have time for questions following Brendan's presentation. So please, if you have any queries for him, make sure to type them into the chat and I will ask them on your behalf at the end of this presentation. So welcome, Brendan. Thank you for being here, and over to you.
Thanks very much, Ben. I'd also like to start off by acknowledging the Gadigal people of the Eora Nation as the First Nations and traditional owners of the land in which I'm coming to you from today. It always was, always will be Aboriginal land. My name's Brendan, as Ben said. I work at the National Centre for Clinical Research in Emerging Drugs of Concern and here at St Vincent's Hospital as well in Sydney. The National Centre for Clinical Research in Emerging Drugs was set up around after the National ICE Action Strategy, following a lot of attention around methamphetamine in around 2015. And so in tandem with the mission of creating responses to methamphetamine harms, we also wanted to get ahead of what the next substance of concern might be. So we set about this other project of developing a network for responding more promptly to emerging drugs of concern. So today I'm going to talk about prompt response and early warning systems for emerging drugs of concerns, touch on new psychoactive substances and some trends in emerging drugs, talk a little bit about what surveillance of emerging drugs looks like, what responses to concerns look like, and primarily drug alerts and notifications, and then talk about the Prompt Response Network project that NCCRED's been undertaking for the last few years. So responding promptly, often the terminology is early warning systems, which is a multidisciplinary interagency network formed by key stakeholders that generate and exchange information to identify early events that pose a threat to public health in the area of new psychotropic substances or emerging drug phenomena, evaluate the risks related to their use, and send out early warnings for the design of effective responses. Some of our stakeholders or some concerns around emerging warning systems as police-based or overly surveillant. So we use the term prompt response network, but you'll see the term used interchangeably throughout the presentation. I quite like this diagram that South Australia produced in this paper led by Andrew Camilleri, which is basically an overview of the South Australian drug early warning system. So you can see here, we've got forensic toxicology, emergency departments, police, clinical toxicology, research units undertaking wastewater analysis, the clinical drug and alcohol services, the evidence service, all sharing data and information that's then assessed and results in the issuance of drug alerts in one way or the other. So the things that we're looking for, in the main, what people think of when they think about emerging drugs and concerns are new psychoactive substances, so substances that weren't included in the Psychotropic Substances Convention in 1971 or the Narcotics Drug Convention of 1961. So these are substances that haven't been included or controlled by those acts and have been produced since. So this slide, this graph shows you from the World Drug Report in 2022 that there's currently about 1,100 new psychotropic substances, with about 100 a year for the last 8 or 9 years being identified. So it's a lot to keep across. What these new psychoactive substances are in the main, this is from the UNODC. They produce through their early warning advisory system, they produce publications about what's been detected globally. So this is global data. And here you can see a couple of things. So you can see the types of new psychoactive drugs. So generally, they're the large one there are stimulants, and new psychoactive stimulants such as cathinones, the synthetic cannabinoids, and what you can see on the top here in that dark blue is synthetic opioids. So everything seems to be kind of stable, a large increase in 2013 for most things. And then the synthetic opioids are certainly increasing over the last 10 years. And new psychoactive stimulants are also continuing to increase globally. New psychoactive substances doesn't include other drugs of concern occasionally, such as fentanyl or GHB. So this is one of the things that we've been watching for in Australia for quite some time now, is if we're going to have the same experience as overseas jurisdictions such as the US and Canada with their overdose epidemics, largely based on fentanyl and fentanyl analogs. This self-report shows on the left is a slide from the illicit drug reporting system run by Drug Trends at NCCRED, which is a survey collected across Australian cities. Self-report wise, there's no increase in fentanyl. Obviously, that self-report has its limitations. So Susie Nielsen and colleagues did some testing in the injecting facilities in Australia, where they looked at the drug paraphernalia, so discarded injecting equipment left over after when there'd been an overdose, and tested the paraphernalia to see what drugs they could identify. And usefully there, they've not identified any fentanyl. So you've got a nice triangulation of data, you've got some self-report, and you've got some toxicology analysis. Another drug of concern, not necessarily considered a new psychoactive substance, is GHB. This is another drug trends report. This is the ecstasy and related drug reporting system by Drug Trends. And you can see here, GHB, which is that yellow line, hasn't changed a huge amount over the last 10 years. On the top, you can see mushrooms have increased quite a bit, but GHB, certainly by self-report, hasn't changed. On the right, though, you can see that harms might be changing. So there's a possible signal here from ambulance attendance data in GHB prepared by the people at Turning Point, where they've tracked GHB-related attendances over time, and there seems to be a trend upwards there. Obviously, there's limitations with ambulance collected data as well, but you've got a signal there. So in terms of surveillance, I've talked about a couple of ways of collecting data already. So this is just a more complete list. So the surveys, so the EDRS and IDRS, collected drug trends are very useful data. Clinical toxicology is very useful as well. And you can see here on the right is the EDNA project schematic, which is a sentinel toxical surveillance system based in emergency departments, where patients that present with drug-related phenomenon and overdose get bloods taken specifically to test for toxicology in drugs. And this is now covering most of Australia, quite pleasingly, and they produce reports about what drugs have been detected in that system. There's the clinical data produced by hospitals, so emergency department triage data, ambulance clinical data, coronial systems produce data that when they investigate deaths, seizure data, so forensic toxicology undertaken by police and customs services, wastewater analysis, which we'll talk a little bit about in a bit, and internet scraping and for crypto markets and social media, drug paraphernalia testing, which I spoke about in that previous one. There's also ongoing work in Victoria around doing that. Anecdotal reports, which is a type of information that's produced by peers and consumers who might not engage with any of the other systems, but will have had a drug experience that merits concern. New Zealand has set up an anecdotal reporting system to enable people to report that. Drug checking, I'll talk about in a bit as well, which is something that's new enough in Australia, formal drug checking, but now permitted in Canberra and Queensland. So drug checking, I thought I would go into just a couple of these surveillance methods that are particularly interesting. Monica Barrett and Fiona Measham have a nice definition of drug checking. It's an intervention that aims to reduce harm, analyze a substance of concern that's submitted voluntarily from the public, importantly returns those individual results to those service users. There's an exchange of information between the service user and the service where harm reduction messaging or advice can be given, and it provides tailored intervention to that service user. On the right is the monthly report that's issued by CanTest, which is the first drug checking service in Australia. This one is from February, where it analyzed 110 samples, and which resulted in some changes once people found out what the substance they were actually consuming was. And you can see here some of the findings around new psychoactive substances, and some of these have resulted in community notices. Talking a bit more about wastewater analysis. So here is treatment level wastewater surveillance for new psychoactive substances. This is a study done by Richard Bade and colleagues, where they've identified over the last 3 years some cathinones in Australia, so ethylone, utolone, mephedrone, methylone, N-ethylpentapone, as well as mirtazanine, which is kratom metabolite, and a novel methamphetamine called methopropamine. So there's the research there. That's an ongoing program in Australia, the National Wastewater Drug Monitoring Program, that produces reports. If you go to the Australian Criminal Intelligence Commission website, and that's done with the University of Queensland and South Australia as well. So that's done at the treatment level. So obviously that's very population type data. The other type of wastewater analysis is event-based wastewater analysis. So here is just from the right of your screen, you can see work done by Jonathan Brett and colleagues around wastewater analysis for psychoactive substances at music festivals in New South Wales. So this is Portaloos, so taking samples from Portaloos and seeing what's in them. So you can see that first result. So all festivals, there was some of the usual suspects: amphetamine, cocaine, ketamine, MDMA. There was also some methylone and etazolem as well, and novel benzodiazepine. So kind of what you'd be expecting there. Less than 50% of the, or more than 50% of the festivals, but not all of them, also detected traces of ethylone, mephedrone, and methacatenone. And there was also norfentanyl detected at 2 festivals, and then ethylpentalone detected at 1. So again, very focused kind of information that's useful to see what's what drugs are being circulated in the community, and depending on how quickly you do the analysis can be very timely as well. This last one, which is internet and crypto markets, people get very interested in, and the drugs and new technologies reports done again out of Drug Trends look at the types of drugs being sold on the internet via crypto markets. So here's the report that they issued this year, looking at Feb 2020 to January 2023, and again, mostly cannabis and benzodiazepines, opioids, methamphetamines, and performance enhancing drugs. There's a full list of everything in the report itself, but it's just interesting to see what's being sold that way. In addition to crypto markets, they also look at Google searches and social media discussions. This is looking at cocaine, for instance, and looking at trends and what people are talking about there. So that can be a really interesting way of just another form of data that's not toxicological. That's a way of triangulating the data and maybe more timely in terms of identifying trends. So what all of these turn into is these drug notifications, so drug alerts. So you can see on the left, here's one that's issued by the government, New South Wales one. So this is the most recent one from last week, where there's concern around isotretinoin circulating in New South Wales Central Coast. And then this is another one from last week, which is an alert issued by a user organization, NUA and DanceWise, around what's in cocaine and that it's containing high concentrations of lidocaine. How these drug alerts get used is subject of this work done by Amy Peacock and colleagues at NDARC and Drug Trends, who did some work through their survey systems to see what awareness of these drug alerts were. So the ecstasy and related drug reporting system found that nearly 50% of people were aware of drugs in that cohort, and 65% most recently saw or heard through social media. And then the illicit drug reporting system, which is a different sample, 27% were aware of alerts, and 63% of people most recently saw or heard about it face-to-face or in services. So there's two different cohorts that are accessing information in two different ways. Monica Barrett's team have undertaken some research around what might be happening or how we can improve that there, and these two very good pieces of work done this year. The issues around drug alerts, that's quite nicely described by, in the first paper, talks about the tensions between how drug alerts are issued. So they need to be clear and concise, but they also need to be relevant for a very wide range of stakeholders with differing backgrounds, different knowledge sets. You need to minimize alert fatigue. So anybody who works in a clinical service knows that if you get too many alerts while you're doing your daily work, you just start ignoring them. So you want to minimize alert fatigue so that people pay attention when they need to pay attention. But you also need to provide as much information as possible. So it's a fine balance to get right. The source of the drug alert needs to be trusted, but they also need to be credible harm reduction sources. So if they're government issued, for instance, people can be having very different experiences with government services where some of them aren't trying to help, and that can be a balance to get right. There's often concern around the intended and unintended effects of drug alerts, that you might be advertising or somehow incentivizing people to engage in more harmful behavior. And getting the balance right with that is really about risk tolerance. So there's always going to be unintended effects from every time you try to do an intervention like this, especially in public health. So it really is about balancing that. And then the final one, which is an interesting one also, is about the alerts and the information are generally made for frontline workers to help them in their work. And it's a different type of alert that might be necessary for people who use drugs to get to them more effectively. You'll see from the numbers that we had from this would suggest that we need to do better at getting to frontline where people are using drugs. We'll go through a few of the more recent drug alerts just to kind of give a tour of what's going around Australia at the moment. And the first one is nitazenes. So here are 4 drug alerts from the last 6 months around nitazenes. So these are drug alerts issued by New South Wales, Community Alert, or ACT, Government Alert, and Queensland. And this is talking about nitazenes, which are a highly potent new opioid. There's concerns that because nitazenes has a much greater affinity for receptors, that it may need more naloxone, or naloxone might not be as effective. Usefully, colleagues in Victoria, New South Wales have written up a couple of case studies of nitazene intoxications where naloxone has been working, but certainly have a look to these publications to see the outcomes. All of these clients did recover from their metonitazene or their nitazene intoxications, and naloxone was used mostly in both of them, oxygen used in all. Cathinones is something people are familiar with as the new psychoactive substance. So cathinones, mephedrone, and here you can see there's a range of alerts around synthetic cathinones across Australia, from Victoria on the left, and then a community notice from issued from CanTest in the middle, and on the right is again another one from Victoria around novel stimulants being sold as MDMA, cocaine, or speed. The other drug alerts that have been a couple are about ketamine substitution or adulteration. Again, another CanTest community notice where somebody's come in thinking they had ketamine. It was tested and was found to be something else instead, 2-fluoro-2-oxy-PCE. And again, in Victoria, somebody thinking they have ketamine and they have 3-hydroxy-PCP instead. So ketamine is sold but being substituted with something else. Counterfeit and novel benzodiazepines are of course a concern. There's just looking at fake alprazolam tablets from an alert last year from here in New South Wales. And the short report on the right is a very nice write-up, not just about the benzodiazepine alert itself, but actually the process by which EDNAV, the Emerging Drug Network of Australia, Victoria, actually found the signal, considered the signal, and progressed to issuing an alert about high-potency benzodiazepine tablets. And then finally, the other drug alert to call people's notice to is from last month, where New South Wales Health issued a drug alert about high-dose MDMA, containing up to 168 milligrams of MDMA, and to let people know about that, to alter their usage accordingly. So the Prompt Response Network is the piece of work that NCCRED started undertaking that started off with work by Susie Hudson and Sandy Mitchell initially, and then very much taken on and ran with by Penny Hill, which joined the team. And the Prompt Response Network is a national network that brings together the existing and emerging early warning networks across the country with the mission of coordinating participants to share information and knowledge for timely public health responses that reduce the harmful effects of emerging drugs. To do this, the high-level objectives are that we wanted to achieve are to establish a national network of new and existing organizations that enables flexible participation and information exchange, develop communication and response protocols that define outcomes and actions for topics of interest, and identify and disseminate the information and knowledge needed to support timely health response and decision-making through a program of activities and supported technology. And it looks like this. So you would have seen the picture of South Australian emergency warning system at the top of the presentation. And that's replicated in each of the states, but differently. And their processes for issuing drug alerts varied enormously. So the first job of actually just mapping out who was doing what in what ways turns into this very lovely representation of that we can clearly see it's a complex system nationally. And what was elicited through that system of co-design was this network that across Australia, each of the states and territories have different stakeholders involved in those systems. They've got a different lead agency in some instances. They've got different health systems and government agencies in each of those states, and the relationship between health systems and government differs. Different communication processes, varied levels of formalized processes for undertaking assessment and issuing of drug alerts and notifications, fragile resourcing in some cases, so services not being funded specifically for this work, just taking it on as an extra thing that they do, and very little connectivity between the states around what threats were or what best practices in this area might be. So the PRN settled on this kind of mission of supporting existing activities in states and territories, enabling where there are existing gaps, and to try and coordinate at a national level. And so we basically have three pillars of the prompt response network. The first of which is the network itself, which are now connected as a broad community of people who are involved with regional and national networks that share information, insights, and opportunities. We have quarterly online stakeholder update meetings of the broader PRN stakeholder groups. That's government agencies, that's community organizations, that's academic groups that are all involved in this work of gathering information, assessing it, and issuing drug alerts to prevent harms. We have been able to set up an online community platform for these stakeholders, which is kind of like a Facebook for emerging drugs. It's called the No Community, and what it basically is an online platform where people can register and join the network. We publish the drug alerts on it. We have forum discussions where people can talk about particular signals. We also have groups which are closed where people can have conversations around things and know what the audience is. So it gives that assurance of privacy for conversations that require that. And it replaces a lot of work that was informal. And so it's a great way of formally connecting people so that if people leave positions or if they come into positions, there's a network that they already have that they can access. And as this is evolving, the No Community Network it becomes a repository of information around drug alerts and about considerations of previous drug alerts. So it's this really valuable tool in institutionalizing knowledge that's often been informal. And so that will be open up for a bit broader membership in this next month or so. The other product that we wanted to build was something to support data exchange and data sharing. So we've built a software package to accommodate the very different types of information that we talked about at the top of the presentation that are involved in surveillance, and provide a national dashboard of real-time signals using minimum de-identified data from contributing jurisdictional agencies. So this is trying to meet that need for flexibility in terms of types of information, and also it's highly secure so that government agencies that are very appropriately concerned with data security and cybersecurity know that they've got that assurance that data is going to be managed in a way that's robust and in line with legislation. And this should help that issue of trends across in different states not being recognized or depending on informal conversations to be recognized. The other product, or final product, is something that's going to come up this month, is just one public website for all of Australia where drug alerts can be found. At the moment, it still is a state-based activity, and so to be up to date with the drug alerts across Australia can be difficult. It involves going to several different websites to make sure that you're getting to the right information, whereas this website will collate all of that information from jurisdictions across Australia so you can see what's happening at a national level. There was, for instance, drug alert set out by several jurisdictions last year around poppy seeds and thebaine, and so that over the course of a couple of weeks became quite, it was a big flurry of activity, and to see what each state was doing involved going to each state website, whereas this is something as an information resource hub that can bring all of that together in one place that's easily read and digested. So the next steps for our prompt response network, again, what we want to look at, how do we get better at getting drug alerts to the people that need them in the places that they need them in a way that they is useful to them. The other thing that we want to look at is on the right here, you can see that slide around New Zealand's anecdotal reporting system. New Zealand's got has had drug checking for a couple of years, and they've got a very highly structured early drug surveillance system that is situated as an intelligence unit with joint police, customs and health input. So they access all of those databases and really robustly assess possible signals with a number of ways of triangulating. One of the things they also have set up is an online portal for people to report unusual effects of drugs. So that is another information data point that can be used to triangulate data around possible early emerging drug threats. And that's something we would quite actively looking into how we might do that in an Australian setting. I want to acknowledge a lot of people for this work, having coming into it more recently. It really is the work of a lot of people. That map, I think, is just such a great artifact in showing you the amount of consideration that goes into mapping out a system like this that has all of those multiple stakeholders, multiple types of stakeholders. So I want to thank Penny Hill particularly, and the rest of the PR and the team, Hayley Murphy and Seb Baird, as well as the advisory groups from the jurisdictions, our peer advisory groups, which gave so generously of their time, and our implementation groups and our consultants too, that have helped bring together this piece of work into something that's got some very tangible outputs now. So just to kind of give you some take-home messages, for clinicians, I would just make sure that you're plugged into your local systems for drug alerts. They're not always obvious sometimes about which state you're in, and are you signed up for the right email list to get them into your account. Consider mechanisms for distribution of drug alerts in your settings. So sometimes because they don't come out very, very frequently, they only come out they usually come out, you would only get a couple of, one every couple of months. It's sometimes not clear who is responsible for issuing drug alerts in your settings and how they might be distributed across it. So is it an email just to clinicians, or do you have somebody who's tasked with pushing up posters or leaflets into waiting rooms and clinical areas? Reflecting back on those drug alert design papers and the work that we've done, really needing to center peer perspectives and experiences around how we go forward with improving drug alert systems to get to make better use and acknowledge the importance of peer knowledge in this space, and also doing it justice by getting it sufficiently integrated into those the settings where it's needed. Naloxone, nitazines are a concern, but naloxone works. So really, that's a really great tool that we have. So making sure that you're across take home and naloxone programs where they exist, and how skilled up your workforce are. The No Community online platform is available for people that might want to, who are working with emerging drugs of concern or are interested in drugs of concern. The platform gets better the more people that are on it. It's still a referral only community system to keep it specific to the work of emerging drugs. So you can get referred by somebody who's already a member, or if you think that you want to join, just email me or email the PRN admin at those email addresses there. If you want to have more information about the PRN ongoing way or the work of NCCRED, you can also sign up for the NCCRED newsletter at that email address. And I will just give one final call out for anybody who's interested in the work. We are currently advertising for a research fellow to continue this work, and now that we've set up some things, put a program of research behind it. So do reach out to me or go to the UNSW jobs site if you're interested in that. And that is where I'm going to finish for today.
Thank you so much, Brendan. That was excellent, and a very exciting possible job opportunity for someone in there as well. Pardon me. We have a couple of questions that I'm hoping to send your way. And if there are any others kind of that people have in the back of their minds, feel free to include those in the chat as we speak as well. The first one I wanted to ask you, firstly, our attendee thanks you for the information, and was wondering if you could comment on the sources of some of those new psychoactive substances. So in particular, there was some curiosity around whether there was any information that helps break down how much of it's coming from kind of local versus overseas versus online. So kind of if there's any information about that, and also the person had a particular interest in knowing whether any or how much came from China, and perhaps what substances might be coming from there.
I don't know that off the top of my head. It depends on each substance. The Australian Crime Commission website does have reports on its seizure data, so that might be one way of doing it. But again, it's incomplete, so that you would need to triangulate that again with some of the online data as well. The drug trends reports are also pretty useful in terms of describing broader trends.
Yeah. Okay. Yeah. Excellent. Thank you. So also you mentioned, obviously the talk was about the prompt response network, and I found the information about the No website really interesting. You mentioned as well that if people want to access that, they can contact you. I guess the question that I had kind of maybe just before you mentioned that was, how do people access it? How do people access this information?
So there's the website itself, which is about drug alerts, and it's actually, we will put on, once we get it up, we aim to put the last year or so of drug alerts on it, which is actually a really useful thing to have. The No online community is, you either get, because it's a referral only community at the moment, to keep it specific, you can either get, if you know somebody who works in emerging drugs, you can ask them to refer you, or you can email me or the PRN admin, and they will set it out. We might expand access a little bit later on so that it's more general, but certainly for the moment we're trying to keep it as specific as possible. Yeah. So that it's, but certainly clinicians especially are people that we want to have on that, because just to upskill and up knowledge people around working in the space, it's really useful to know what drug alerts are going around, the experiences that people have had with them, and also the questions that people are asking. So it's a useful platform for that. And not just clinicians, but also any kind of service providers, we would like to have them on. So some organizations will be able to join just by merit of being in an organization. So if you are interested and you think your organization should have access to that, have a conversation with somebody, or email us. We can see about just adding your organization as opposed to just adding an individual onto that platform.
Gotcha. Excellent. Thank you. And also, Brendan's contact details are in the slides. There'll be a PDF available of those, and also it's on the screen right now. Thank you. So you mentioned as well that one of the important roles of drug alerts and this information is not only to provide that substance-related information to workers, but also to people who are using substances. So I guess, do you have any information for our attendees today around how they might be able to support people who are using substances to access this information directly? Are there any resources out there that you're aware of?
I mean, a great resource is to just go to the user organization for your jurisdiction. So New South Wales has some excellent stuff, and especially through Dance Wise as well for that kind of different market. AVIL, I would suggest as a place to go to to find out who you should be talking to in your area. So working with your peer workers if they're in your service, but also engaging with your user organizations is this really powerful way of making sure that your work is getting to the place that it needs to go.
Yeah, absolutely. And I think this is probably simultaneously maybe a difficult to answer question and also a similar answer that maybe you just kind of provided. You presented some really wonderful data on those drug trends, and I certainly was kind of blown away by the complexity of that map that you showed. It kind of describes how that information arrives to where it needs to go. So I guess currently, do you have any advice about the best way for workers to access information about drug trends that's not only evidence-based, but also kind of easy to access and easy to understand? Like I said, might be a difficult to answer question.
And I'd go back to the user organizations again as a really good conduit for making sure that they're often they republish alerts sometimes in a format that's better suited for settings that aren't office walls, which is kind of where the drug alert sometimes ends up. So I think going through your making sure you've got the resources from your user organizations is one way of making it easy to understand. Going to webinars like this to upskill you on things, because it is one of the challenges in the area. It is because every week I'm having to learn a new word because they keep making new psychoactive substances. So it is a hard place to kind of keep across. Those resources from Drug Trends, NDARC will often do a webinar as well, and that's an area in which you can listen as well as just read, because the documents can be the trends. The reports from the UNODC or the national ones can be quite voluminous tomes because it goes through all of the biochemistry. So I think those kind of places are good places to get a snapshot or a relevant curating of the information.
Perfect. Thank you so much. And then the last thing was probably not so much a question, but just a comment. How interesting that information that you presented around kind of best practice approaches to drug alerts, and just appreciating that it is a very difficult balance to achieve. There's kind of a lot going on.
Yeah, there's a lot of consideration that goes into it. There's a lot of behind the scenes work, and to get those balances right between enough alerts and too many, and how timely between a signal being received and how much testing and how sure do you want to be before you it's very human work. So that's the other thing, is you can only protocolize things to a certain amount. Every context is different. Every drug experience is different. The combination of setting and drug use and drug policy means that the harms are always kind of going to be different for each situation. So it's never going to be a computer program that does all of these things. It will always have to involve people. It will always have to involve peers. Because it's always going to be different. It always needs that human consideration.
Yeah, and it's really nice to know that there's that depth of consideration that goes into this work. It's really nice to see that human side of it. So thank you for helping us see that. That's all the questions that we have today. So, actually, there's one more. Just got it. Okay, so one of our listeners, they're a new AOD worker, and they're curious, do you know which organisation I can follow to receive drug alerts in South Australia? They're in Murray Bridge. Quite a specific one, but if you have any information off the top of your head.
I don't have information off the top of my head. No, DASA might be able to guide you there if you work with DASA, but I'd imagine they would be quite across it.
Yeah.
Yeah.
Yeah, excellent. Thank you. And yeah, just saw that one flashing, so got in right at the last minute. Thank you. I'd like to thank you again very much, Brendan, for taking the time out of your day to present us with this information. It's extremely valuable. For everybody who's watching, please join us again next Wednesday at 10 a.m. For a presentation on vaping in young people. That's going to be presented by Dr. Gary Chan and Rebecca Mounsey. Otherwise, thank you again to you, Brendan. Everybody have a lovely week, and we hope to see you at the next webinar.